All right, let's talk about the ECG. You know, those squiggly lines that can look pretty intimidating at first? Well, we're going to demystify them. Together, we're going to turn all that chaos into a clear language. I'm going to give you a super reliable system that'll make reading any ECG feel totally straightforward and, actually manageable.
Yeah, I get it. If you've ever looked at one of these and just felt completely lost, trust me, you are not alone. It can seriously feel like trying to read a foreign language. But here's the thing. By the end of our time here, you're going to see it's not a language, it's a code. And I'm about to hand you the key to crack it.
Okay, you ready to dive in? So the real secret to reading any ECG isn't about memorizing a million patterns. It's about having a system, a checklist. And this right here, this is our secret weapon. It's a simple 5-step roadmap that's going to guide us every single time. We'll start with the absolute basics, calibration and voltage. Then we'll check the pulse, the rate, and rhythm. After that, we'll take a look at the heart's electrical highway for any traffic jams or blocks. Step 4, we size up the engine itself, looking for hypertrophy. And finally, we'll figure out our direction with the cardiac axis. Seriously, if you follow these steps, you will not get lost.
All right, step 1, the basics. And I mean, first things first. Before you even think about interpreting a single wave, we've got to make sure the machine is set up right. Is it properly calibrated? We're talking paper speed and voltage.
And this one check right off the bat gives us some amazing clues. So if you see low voltage, where all the waves are kind of small and shrunken, you have to think, what could be dampening that electrical signal? Maybe something like fluid around the heart or even just obesity. But on the flip side, if you see high voltage, those big, towering waves, that's a huge clue that the heart muscle itself might be enlarged, or what we call hypertrophied. See? It's our very first piece of the puzzle. Okay, so our machine is calibrated, we've checked the voltage. Now it's time for our first real glance at what's going on. Step 2 is all about mastering rate and rhythm. Basically, how fast is the heart beating? And is it beating like a metronome, or is it all over the place? This is absolutely fundamental. Now, for any regular rhythm, I want you to burn one number into your brain. Just one. And that number is 300. This is going to be the simplest, fastest way you'll ever learn to estimate the heart rate. And trust me, it works like a charm. So the first thing you have to do is decide, is this rhythm regular or irregular? Because that's going to tell you which tool to pull out of your toolbox. If it's regular, it's super easy. You just find 2 of those tall, pointy spikes, the R waves, and you divide our magic number, 300, by the number of big squares between them. Simple as that. But what if it's irregular, like in atrial fibrillation, where it's just chaotic? Well, then you can't use that trick. Instead, you'll take a 6-second strip, count up all the QRS complexes you see, and just multiply that number by 10. Boom, you've got your average rate. All right, moving on to step 3. I want you to think of the heart's electrical system as a superhighway. And our job as ECG detectives is to look for traffic jams. We're on the hunt for blocks, anything that's slowing down or completely stopping that electrical signal from getting where it needs to go. So how do we spot these traffic jams? We measure something called the PR interval. This is basically the travel time for the signal to get from the upper chambers, the atria, down to the lower chambers, the ventricles. Normally, that trip should take between 120 and 200 milliseconds. On the ECG paper, that's easy to remember. It's just 3 to 5 of those little tiny squares. That range is our normal speed limit. So what happens if that travel time, that PR interval, is consistently longer than 5 small squares? Well, that's what we call a first-degree AV block. The best way to think about it is like a minor traffic delay on the highway. It's consistent. The signal always gets through. It's just a little bit slow every single time. Now, things get a little more interesting with second-degree blocks. There are 2 types. First, you've got Mobitz 1, or Wenckebach. With this one, the PR interval gets a little longer, and then a little longer, and then a little longer, until, pop, a beat just gets dropped. It's a predictable pattern. Long, longer, longer, drop. But then you have Mobitz 2. This one's different. The delay is constant, it looks fine, and then bam! Out of nowhere, a beat is dropped without any warning. And that unpredictability, that's what makes Mobitz 2 so much more serious. And finally, we have the worst-case scenario. This is a complete shutdown of that electrical highway. A third-degree or complete heart block. Here, there is zero communication between the atria and the ventricles. They're totally disconnected, completely dissociated. The atria are doing their own thing, the ventricles are doing their own thing, and they're not talking to each other at all. This, as you can imagine, is a true medical emergency. Okay, let's take a breath. We've checked our rate and rhythm, and we've inspected the electrical wiring for any blocks. Now, for step 4, we're going to size up the heart's engine itself. We'll use the ECG to see if any of the chambers are getting too big, looking for atrial enlargement or ventricular hypertrophy.
So to check out the atria, we're going to zoom in on the P wave, especially in lead 2. And there are 2 classic patterns to look for. For left atrial enlargement, you're looking for a wide, notched P wave that kind of looks like the letter M. We call this P mitrale. M for mitrale. See? Easy. For right atrial enlargement, on the other hand, you're looking for a tall, pointy, peaked P wave. This one's called P pulmonale.
Okay, now for the big pumping chambers, the ventricles. Here, we're looking for bundle branch blocks, and the key leads are V1 and V6. For a right bundle branch block, or RBB, the classic sign is in V1. You're looking for that RSR prime pattern, which makes a very clear M shape. You can almost see bunny ears. For a left bundle branch block, or LBB, the pattern's different. You'll see a deep, downward wave in V1, and then a broad, kind of clumsy-looking R wave over in V6.
Now, what happens when the heart's main workhorse, the left ventricle, gets too big and muscular? We call that left ventricular hypertrophy, or LVH. And it makes perfect sense what we see on the ECG. A bigger muscle creates a bigger electrical signal, right? So you get these really exaggerated forces. You get these super deep S waves over in V1, and then these incredibly tall R waves in V5 or V6. They're like mirror images of each other, just really amplified.
And there's actually a super simple formula to see if it meets the criteria. You just do a little bit of math. You measure how deep that S wave is in V1, add it to how tall the R wave is in V5 or V6. And if that number is 35 millimeters or more, that is a huge, huge signpost for LVH. Okay, we're on the home stretch, our final big step in the system, finding the cardiac axis. Now I know, axis sounds complicated and intimidating, but I promise you, it's not. All it means is, what's the main overall direction of the heart's electricity? Just think of it like the heart's electrical compass. And you're not gonna believe how easy it is to figure this out. You only need to look at 2 leads, lead I and lead ABF. That's it. The easiest trick is the 2 thumbs method. Look at the main spike, the QRS, in lead I. Is it pointing up? Thumbs up. Now look at AVF. Is it also pointing up? 2 thumbs up. That means the axis is normal. Now, what if lead I is up, but AVF is down? Your thumbs are pointing away from each other. They're leaving each other. That's left axis deviation. See how simple that is?
So you might be asking, okay, but why do we even care about the axis? Well, one huge reason is that it helps us find something called a hemiblock. This is just a block in one of the smaller roads of the left bundle branch, and the axis tells us exactly where that block is. The takeaway is really simple. If you have left axis deviation, it points to an anterior hemiblock. Right axis deviation, that points to a posterior one. The axis is like a little GPS for finding the exact location of the problem.
Okay, now let's quickly touch on some of the most critical things you can see on an ECG. Signs of a heart attack or ischemia. First, if you see a really deep, wide Q wave, a pathological Q wave, that's often a sign of an old, completed heart attack. It's like a scar. Now, ST segment elevation, that's the big one. That's the classic sign of an acute, ongoing injury to the heart. This is an emergency. And finally, if you see ST depression or an inverted T wave, think of those as warning signs. They suggest ischemia. The heart muscle just isn't getting enough oxygen.
All right, to wrap things up, I want to leave you with 3 super high-yield patterns you should just commit to memory. These are real game changers. First, the S1Q3T3 pattern. If you see that, you've got to think about a pulmonary embolism. Second, know the signs of hypotassium or hyperkalemia. It starts with these tall peak T waves, then the QRS gets wide, and eventually it can look like a sine wave. And third, always check the QT interval. If it's too long, that's a major red flag for a really dangerous arrhythmia called torsades de pointes.
But all of this, all these rules and patterns, brings us to the single most important, number 1 golden rule of reading an ECG. And it's this: the ECG is just a tool. It gives you clues, but it is not the final diagnosis. You have to correlate what you see on that piece of paper with the actual living, breathing patient in front of you. Always, context is everything.
So there you have it. You now have a system, a reliable, step-by-step guide to approach any ECG you come across. You've got a framework to turn those confusing squiggles into a ton of useful information.
The question for you is no longer, what on earth am I looking at? Now the question is, what will you look for on your next ECG?